Okay. So, a patient of 74 years old, male, with a medical history of hypertension, COPD, and cancer, which is in remission now. And he had cough and fever for 3 days before coming to the hospital. And the last day before coming, he had an increasing dyspnea. At the emergency room at H0, he had a mental confusion, mottling, crackles, fever, 39, respiratory rate was 40, he was tachycardic, 104, hypotensive, 69/34, and the mean value was 45. It is a true case. SpO2 was 90% with already 10 liters per minute of oxygen. You decide, I don't ask the question, you decide, this is life. You decide to intubate the patient and to give 500 of crystalloids. My question is, do you initiate norepinephrine at this stage? Yes, no, I don't know. Very simple question. So, who votes for yes? Okay, for no, some people vote for no, and I don't know. Okay. Can you comment who votes for yes? Yeah. Can you comment? Someone?
We discussed this in the previous case, so it would be good to have people who say no to comment for the no.
Okay, comment for the no. Who comment for the no?
One of the two. You were two saying no, I think. Yes.
From Massimo Antonelli team.
I think you may need more fluid before start norepinephrine.
Yes, this is why you said no. I understand, but
yes, before increasing the vascular tone, you have to increase the volume, the blood volume, in order to have more unstressed volume to be recruited in stress volume.
Maybe you've seen, maybe just because it's written a bit smaller, the question of Jean-Louis is also related to the intubation, not just to the blood pressure.
Sorry. No, I was thinking about the norepinephrine.
Okay, so the question of Jean-Louis is, you decided to intubate, okay, do you give fluids or do you give noradrenaline only, also? We discussed that before, but it's good that we talk about this again because I think it's important.
I was going to say no, not because I don't think the patient should raise pressures, but because I wouldn't want to delay putting the central line to give noradrenaline. So I would probably consider giving something like phenylephrine in a bag, or just a milligram of adrenaline that will leave from saline and then it run through, or even possibly dopamine, but the heart rate might make dopamine my third in line. But the patient that definitely needs raise pressures before positive pressure.
okay, just to remind you that the low DAP here it was 34 meters of mercury, and after intubation maybe less, of course, and so this suggests a decreased arterial tone. This, for me, not only for me but for physiology, suggests the septic origin of shock could be another cause of vasodilatory shock, like anaphylactic shock, but in this context it is clearly sepsis. And also this insight to administer vasopressor urgently. So this is a very good way to identify patients who need vasopressors. And this was said by the SSC. Yes.
I just want to ask a question.
Yeah.
If you take the 3 large studies that were done recently, Process, Arise, and all, and you look at the control arm, fully half of the people in the control arm did not get a central line and received pressors. So is it absolutely necessary to put in a central line in initial management of a patient with shock, or can you use a peripheral IV with the understanding that you will then move to a central line at a later point?
Exactly. Yeah.
Be careful Yes, I mean, I agree with your answer. We have to be careful in interpretation of these data from process and so on. Remember that 20%, one patient every 5 patients, did not get to the ICU because they were cured from their septic shock requiring vasopressors within 6 hours. So, I mean, we need to be careful there. I mean, and this is not totally real-life patients. So in a real-life patient like this one, it will not be cured in 6 hours. And this patient will require vasopressor. So I agree that the urgent aspect is you put an IV line, whatever it is, to give vasopressors, and as soon as possible you put the central line.
Okay, and so it was recommended by the SSC guidelines, not the last version, but the previous one. Okay, here 34 meters of mercury before intubation. I think that the patient needs vasopressors. So the first take-home message is this, regarding the initiation of vasopressors urgently in case of low vascular tone and low DAP. So we move, lactate was high, not surprising. Renal insufficiency already, CRP was high. And before intubation, acidosis, which was mixed, because PCU2 is not so low, it is 42. And of course, metabolic acidosis. And this is a chest X-ray, maybe you do not see very well, but bilateral pneumonia, in fact. So he received saline, norepinephrine, propofol for sedation, could be discussed, but this was given, and antibiotics after some cultures. And heart rate after, I don't see very well, but heart rate after norepinephrine and saline was still high. Arterial pressure was 80/38, and the mean value was 52. CVP 10, because we had time to insert catheters. We are after intubation. And pulse pressure variation, the patient is sedated. Pulse pressure variation was 7%, but is ventilated with a low tidal volume, 6 ml per kilogram. Is more directly hypoxemic, less than 200 PF for the PF ratio. And my questions now is which level of MAP will you target? 55, 60, 65, 80, 90? Who votes for 1? 55. 55. Nobody? 2, 60. 3, 65. Many people, I think. 65 is the magic value. Everybody has this value in mind. 80. 1, 2, 3, 4. So it's not a stupid question. And 90? Nobody. Okay. Just to remind you that 65 also comes from this study showing that the MAP under 65 was the best predictor of mortality in this series of septic shock patients. So it makes sense to answer 65. Also, it suggests that not only the deepness, but also the duration of hypotension is important to take into account, because this is the MAP under 65. So this is a recommendation of the Surviving Sepsis campaign. Just to mention that in this multi-center randomized clinical trial, 2 levels of MAP were compared in a randomized fashion, 65, 70, and 80, 85. There was no difference in mortality. There was a signal in terms of renal function, essentially in patients who were previously hypertensive and who were in the arm of high MAP, better renal function in this population. This is why, with Maurizio Cecconi and Daniel De Backer and others, we first said we recommend initially target a MAP of 65 at least, And we suggest a higher MAP in septic patients with a history of hypertension. So this is the case here, because I told you he had hypertension, so maybe we can.
Yes, but Jean
maybe we
Louis, there
can
was
start
something-
by 65 or...
But
Yeah.
you said something important, that in the consensus and also in the trial, the attempt to reach a higher pressure was only done after adequate initial resuscitation, which is not yet the case here. Here we are just in the initial assessment of your patient. You are 30 minutes after intubation. Of course, at this stage, free resuscitation is not yet completed, and so I strongly disagree with the fact that we can, even this patient was previously hypertensive, that it is the right time to do so. So I think that at this stage, 65 would be the good target. Then assess the fluid responsiveness of this patient, and when fluid administration is okay, then only at that time consider high blood pressure. Otherwise, you may vasoconstrict very markedly some areas that are not well perfused at this stage.
I just want to add that 80 is not a very high value if you compare to normal people. The average mean MAP in normal people between 18 and 50 years old is 89. So 80 is high, but it's not very, very high. Yeah.
Have you found that patients that are very vasodilated to start with, so very low diastolic blood pressure and a high heart rate, are they able to achieve this level of mean arterial pressure with vasoconstrictors?
I think so. You know that if you look at the real life and some registries, some studies, very frequently, even in the study by Daniel, we have exceptionally MAP of 65 when you look at all the patients. In general, it is between 70 and 80. And even in the Netherlands, I had a pro-con debate one day against Jan Bakker about this. And I discovered that in all his studies, the mean value, the mean of the mean was 80.
Question there?
So in this exact study, it's actually that there is no enough separation that happened between both groups. This is the first point. Second point, that it mentioned that for hypertension, it's just for the patient that had got uncontrolled hypertension, not just with history of hypertension. So the patient should be on medication that or never been diagnosed before, but not in controlled way. And as well with the current parameters, noradrenaline or norepinephrine exceeding 0.2 at the moment, if you'd like to reach MAP of 80, this means that you definitely develop a lot of side effects after that before getting any benefits.
Yeah, but what I think really it is there is a safe range between 65 and 80. This is my profound thinking. Really, a safe range between 65 and 80. So it's not criminal to go to 80, but if you are between 65 and 80, it's okay.
I think it's important to remember that all these medications we use have side effects, especially on the microcirculatory level. So there have been studies done by Dr. Lund out of Rochester with looking at tissue histograms in liver that showed dopamine, levofed, dobutamine can result in intra-organal shunting of blood and oxygenation requirements. So I think to push someone to 80 means you're going to have to use more of the vasopressor.
Of course.
And I think I think that should be balanced against the risks of using more of a vasopressor.
Of course. Yes, I agree. I totally agree with you. Okay, we can move on to the next question. So what now you have 52 of for the mean value of MAP. What do you do in terms of treatment? We spoke about the optimal target. Okay, 65, 80, 70, maybe 72. And what do you do now? Infuse fluids first and reassess, of course. Increase norepinephrine dose first and reassess. Do both at the same time. Give dobutamine or nothing else. You are happy with this picture.
Jean-Louis, you have 5 minutes to save this
Okay.
patient.
So who votes for number 1? Fluids. 1. No, for number 2, norepinephrine first, at this stage. For number 3, both at the same time. More people. Number 4, dobutamine. Nobody? And you are happy, you do nothing else. You want to spend the rest of your life in a prison. Because this is why. No, okay, you need to do something. Lactate is still high, MAP is still low. You need to do something. What do you answer, Maurizio?
I would do both at the same time, but I would like to have some guide to see whether one or the other works. I would like to do some assessment of cardiac output when I give the fluids.
I would have answered number 2 because still there is some reserve for vasoconstriction. He has a low vascular tone still, so I would have answered number 2. And in terms of hemodynamic monitoring, you can choose many answers. Echo and calibrated cardiac output monitoring, transparent thermodilation, PA catheter, or nothing more than arterial pressure monitoring. Who vote for echo? Number 1. Yes. Number 2, and calibrated. You know what is in calibrated? Could be FlowTrack, ProAct, or LeadCo Rapid. And calibrated? You? Why?
Why not?
In this situation of sepsis and use of vasopressors, can be not valid. So I would be very, very cautious about the use of uncalibrated cardiac output monitoring device.
However, if you look at the data for trending and pulse pressure variation and stroke volume variation, it seems that the accuracy of the value of cardiac output is less important than the drug.
Yes.
It wouldn't give you any valuable information on the absolute value of cardiac output.
It's true for PPV, it's true for the trending, yes, but...
Well, maybe more important. I mean, you just have cardiac output measurements and nothing else. And in this kind of patients with quite marked RDS or severe RDS and also renal impairment, you want to have some additional measurements. So that's why I would go for something which is not more than just the cardiac output. So the uncalibrated just give you cardiac output. Admittedly, we can discuss on the accuracy, but more than the accuracy, you just have a number of cardiac output which gives you limited information here.
Yeah. Who votes for number 3, transparent thermodilation? Nobody?
Well, I can use. But
Number 4, PA catheter?
I would use.
Yes. Antonio Pesenti? Classical generation? And number 5, I think that we need to do something at this time.
Yeah.
Because the patient has, as Daniel said, has a severe shock plus ARDS.
But I think if we comment here, typically we can accept 3 and 4. I mean, it's really depending on what your unit is customized to do. So as a physician practicing both, I can use both. But it will really depend on my colleagues and the nurses and others, because if you are alone using your PA catheter, the data will be minimally interpreted. If you are in a unit never using the transparent thermodilution, it will be exactly the same aspect. But both have really interesting factors that can be interpreted for the patient.
Okay. So second message, when shock persists in spite of adequate, I don't know, but some fluid therapy, we think that arterial pressure monitoring is not sufficient, and we need to consider a cardiac output monitor, but as said by Daniel, in this situation, you need more variables, essentially when you have an ARDS which is associated. And this is what we already said in these 2 papers. We have to finish now? Okay, we have to finish, so thank you very much. Just to say that we performed echo more or less normal. And we put transparent hemodilation system in this patient. Okay, so we need to finish this session.